vascular lesions or vascular rejection. So this is important, vascular rejection in relation to renal transplant, because we know that vascular lesions or vascular rejections, they are like sometimes they may be associated with acute antibody mediated process, and obviously they can be associated with acute T-cell mediated rejections also. So when they are associated with T-cell mediated rejection, they will respond to steroid therapy. If there is a policy that in your hospital for a borderline cellular rejection for ACR money, you give 3 pulse steroid, or maybe a vascular rejection, vascular component of rejection, you may try giving 5 pulse steroids. But there will be some vascular rejection which will not respond, and you may have to think about ATG also. So before planning for ATG, sometimes you do a repeat biopsy, and the repeat biopsy may show that the vascular rejection has progressed from low grade to a high grade. So before I start with the vascular thing, so I just want to tell you briefly about in the BAMF classification system how these vascular lesions or how these vascular rejections they were graded. So majority of you are in the final year? No. How many are there in final year? So 2 people. So you are example next month. Okay. And the rest is first year, second year. So acute vascular rejection has been traditionally suggested to be a predictor of poor kidney allograft outcome. And based on the severity of vascular inflammation, there are 3 grades of intimal arteritis or endotheliitis. So for vascular rejection, the terminology we use is, we can also say intimal arteritis, because intimal arteritis means because the vessel wall has got 3 layers. There is a tunica intima, there is a tunica media, and there is a adventitia. So when we say intimal arteritis, that means the inflammation is there only in the intima. Okay, so I'll show you that. So for example, as you can see in this blood vessel wall, so this thing is intima. Okay, similarly this is intima. So this complete thing is a vessel, and you are seeing this is the vascular lumen, and the vascular lumen has got these orange color cells. These are RBCs. There are scattered lymphocytes also, which are there in the vascular lumen. Now if you follow this up, this vascular wall, so this is the intima, this layer is the media, and then outer side is a adventitia. Adventitia is more prominent in the larger vessels, and we know kidney biopsy, when you are seeing it, is not a larger vessel. These are smaller vessels. The largest vessel in a kidney, you can think of a renal artery, because you are not going to see the renal artery. You are going to see the subdivisions of renal artery, interlobular vessel, arcuate vessel, you can see. So these are very smaller vessels. So adventitia will not be very prominent in majority of these vessels. So what I want to show you is, now this intima, this is showing this cell. So when I say this cell, that means blue color nucleus. Okay. So this flattened looking cell, a flattened color nucleus, this is the endothelial cell. When you see the endothelial cell lifted up, and there is a lymphocyte beneath the endothelium. For example, just diagonally, if you come here, you can see the endothelial cell is lifted, and there are some cells beneath that. Okay, so these dark blue cells, round cells, these are lymphocytes. So when you see the lifting of the endothelium, beneath that there is a lymphocyte. That means it is intimal arteritis, or in other words, also called as endotheliitis. Now, if you see a lymphocyte above the endothelium, then it is not intimal arteritis. It has to be beneath the endothelium with lifting up of the endothelium. And there could be some kind of a reactionary changes also in the endothelial cell nuclei. There may be some enlargement of the nuclei or swelling of the nuclei. So this kind of a thing where the vascular circumference, it is less than 25% of the vascular circumference is involved by endotheliitis. That is 2A. So type 1 rejection is a tubular interstitial type of rejection in which you will find tubulitis, you will find interstitial inflammation more than 25%. Okay. So that is a type 1 rejection. That is divided into 1A and 1B depending on the severity of tubulitis. If tubulitis is severe, that means more than 10 lymphocytes infiltrating into the tubular cross section, then it becomes 1B. If tubulitis is mild to moderate, then it is 1A. When we talk about vascular rejection, either it is type 2 or it is type 3. So in type 2, there are 2 divisions. One is type 2A. So that means the endotheliitis is involving less than 25% of the luminal circumference. So if this entire thing is a luminal circumference, this endotheliitis is involving this area and this area. It constituted less than 25% of the entire limb. Okay. On the other hand, look at this vessel. So this endotheliitis is involving more than 25% of the luminous surface. And this area is fine, but this complete area from this area till this area, this is all endothelitis. It is all lifted up endothelium and there is a significant lymphocytic infiltrate within the endothelial lining. Okay, and you can also see these RBCs which are there in the vascular layer. So this is 2B. Then there is a type 3 rejection. The type 3 vascular rejection is, I have shown you media which was showing, which was appearing like this. You can see some. So whenever in histopathology, you don't have to become nepropathologist, but the thing is, understand whenever we say H&E stain, hematoxylin eosin stain. Okay, this is the hematoxylin eosin stain. It will appear hematoxylin is blue in color and eosin is pink in color. So you are going to see everything blue or pink. So blue are mostly nuclei and pink is always cytoplasm. So whenever smooth muscle cells are there, they will appear pink. And whenever nuclei is there, it will appear blue. So you can see some nuclei here in the muscle layer also. So these are the smooth muscle nuclei or nuclei of tunica media. Now look at this vessel. This complete thing is pink, this area. That means there is a fibrinoid necrosis or necrosis of the vessel wall. So when there is complete necrosis of the vessel wall, it is considered as a type 3 vascular rejection, okay, or a very severe form of vascular rejection. And the other form of type 3 vascular rejection is, one is there is complete fibrinoid necrosis, the other is if you find transmural inflammation. That means the neutrophils or the lymphocytes, they are seen throughout the wall of the blood vessel, okay. So if it is a transmural arteritis or fibrinoid necrosis of the vessel wall, it is called as a type 3 vascular rejection. It is said that type 3 vascular rejection, initially we used to think that whenever there is a severe vascular rejection, that means type 3, they are mostly associated with acute antibody mediated processes. And type 1, type 2A, 2B, they are commonly associated with T-cell mediated rejection. So when you treat these rejections with steroids, they will respond. But if it is a type 3 vascular rejection, it is not like, in medicine it is not like 100% this will happen like that. But initially the thought process was that antibody mediated process will produce only severe vascular rejection, that means type 3 vascular rejection. And it will not produce type 2A or 2B kind of vascular rejection. So this is regarding the first PAM meeting which happened in 1991 and it got published in 1993. So in that, if you look at the categories, so there was acute rejection grade 1, which is considered as a mild acute rejection. Mild acute rejection means dominantly tubular interstitial type of rejection. They now used to say 1A, 1, 2A, 2B, that kind of thing was not there. It was just said that, okay, grade 1, which is a mild, grade 2, they used to say there could be a vascular rejection with mild or moderate intimal arteritis. Okay. Mild or moderate intimal arteritis, that was labeled as cases with A, significant interstitial inflammation, with severe tubulitis, more than 10 mononuclear cells, and or B is, so 2B, grade 2B, they used to label it as vascular rejection and no separate label. It was just grade 1, grade 2, grade 3. Okay, so grade 3 was severe acute rejection. Severe acute rejection means there will be a transmural kind of, so what they have said is, cases with severe intimal arteritis or transmural arteritis with fibrinoid change, that means fibrinoid change and necrosis of the medial smooth muscle cells, or recent focal infarction or interstitial hemorrhage without other obvious cause, are also regarded as evidence for grade 3 rejection. Now we don't use these terminologies, grade 1, grade 2, grade 3. What terminology in 1991 categories they show. So I'll show you. So these are the terminologies which we use. So 2A, 2B and 3. So 2A, 2B I have shown you and even 3 I have shown. So then antibody mediated rejection, this was the time when C4D came into the picture. And the definition of acute antibody mediated rejection, just look at here. So in 1991 category, so there was hyperacute rejection. Now we don't use that terminology, hyperacute rejections, at least in the recent classification system, because with a good immunopathological workup which we do, that means you do CDC cross match. This was the time they were doing only CDC cross match. So when you are doing CDC cross match, when you are doing flow cross match, when you are doing DSA, when you are doing PRA and all that, so chances of getting a hyperacute rejection are highly unlikely, except in a ABO incompatible setting. ABO incompatible setting, somehow you do whatever. a case has to go towards a hyperacute rejection, it will go. We don't know the reasons till now, till date, that what are the causes that some patients of avian compatible transplant in the first 2 weeks they have a hyperacute rejection, and some patients they do absolutely fine. So in that, your DSA will not have, it is only the histopathology, the kidney biopsy, allograft biopsy, which will help in definite diagnosis. So hyperacute rejection is in present setting, it is commonly seen in avian compatible setting. So in the 1997 categories, the antibody-mediated rejection was considered as immediate, hyperacute, or delayed, and there was no further description that how antibody-mediated rejection will look like. The only thing was, if it is a severe vascular rejection, it is likely antibody-mediated rejection. Then 2003, the C4D came into the picture, so it was considered that if there is ATN-like picture, if there is along with ATN there is C4D positivity plus a minimal inflammation. Second thing was capillary margination or thrombosis. So that means TMA, or margination means there is microvascular inflammation, and C4D positivity. And the third was arterial vascular rejection, that we have labeled as B3. So that means 97 category in 2003 also, when C4D came in, it was thought that when there is a B3 lesion, there is a severe vascular rejection along with C4D positivity, then only you think of acute antibody-mediated process. If there are V1, V2 lesion, consider this as a acute T-cell mediated process. So then further on, it was suggested that okay, acute antibody-mediated rejection C4D has to be positive. There could be ATN, there could be TMA, thrombosis, and all that, and obviously V3 lesions. Now, revised 2013 classification, they came up with a criteria that even if there is any V form of lesion, that means intimal or transmural arthritis. So that means any V more than 0. That means V1, V2 or V3, any lesion. It could be due to antibody-mediated process. So presence of, that's why you always ask, vascular rejection is there, because you are concerned about the vascular part, because you know you will be able to handle the tubular interstitial rejection. But if there is a vascular rejection, then there is a possibility that this could be AMR. But the thing is, if there is no thrombotic microangiopathy, if C4D is negative and there is no microvascular inflammation, by microvascular inflammation I means there is no glomerulitis or PTC capsulitis, then the chances of antibody-mediated rejection is less likely. So we'll say that way it looks like a grade 2A kind of vascular rejection, and it is not looking like AMR because all these findings are not there. So I show you 3-4 cases. So this was a patient, first transplant done in 2005 on a wife, CMV in 2005, second transplant done, brother-in-law. This was a HLA mismatch, basic disease was unknown, no induction was given. Graph biopsy on POD6, there was rise in serum creatinine. So this was a biopsy and it showed no significant, practically very minimal kind of interstitial infiltrate which was there. You hardly see some blue cells here and there. Okay, but what was seen was there is this vessel which I show in the high magnification. So this vessel, you can see these flattened endothelial cells here. You can see the endothelial cells here, but there are lymphocytes beneath this area. So that means there is a mild intimal arthritis. So you will label it as a 2A or 2B. Tell me, do you think it is involving more than 25% of the lunar circumference or less than 25? Exam word.
Less than 20.
So you label it as 2A kind of vascular rejection. So you can see this. There is a lifting of endothelium, there is a lymphocyte here. Okay. So just compare with this endothelium. There is no lymphocyte beneath this, but there is a lymphocyte beneath this with lifting of endothelium. In addition to that, there was very mild peritubular capsulitis. You can see these PTCs, one cell here. This PTC is absolutely empty. This PTC is empty. There are 1 or 2 cells here. 1 or 2 cells here. So mild kind of peritubular capsulitis, nothing more than that. So this, you can label it as a BAM2A kind of vascular rejection. There is one more entity which came in, which was called as isolated V lesion. So isolated V lesion or isolated vascular lesion means there is no significant interstitial inflammation. There is no tubulitis. What you are seeing is only one vessel with evidence of mild internal arthritis. So what does that mean? I'll go into further details, but first I'll show you these 2-3 cases. So this patient improved with 5 doses of inhaled PET. So most likely it was a T-cell mediated rejection only, which got resolved. So this concept of isolated B lesion came in 2009, and they formed a working group also. So I'll highlight in detail what are these isolated B lesions in further few slides. So we come to second case. This was a 37-year-old female, was a donor. This basic disease, diabetic nephropathy, IL-2 induction, urine output decrease on POD1, graft Doppler increase, RI, absence of diastolic flow with good perfusion. So you can see that this biopsy, as compared to the previous biopsy, is showing a lot of blue cells, okay, in the interstitium. So you can see a lot of blue cells in the interstitium. So when you see a lot of blue cells in the interstitium, you know most likely there is an interstitial inflammation which is there. So these are the globuli, and you can see the globulars. Majority of them, they are absolutely, these are the capillary loops. These white appearing areas, these are the capillary loops, which are absolutely empty. They are not showing any cells. But some of the capillary loops were showing some cells. So when you see some cells within the globular capillary loops, in a native kidney biopsy, you label it as endocapillary proliferation. But in a transplant biopsy, you label it as globulitis. Okay? So this is a transplant biopsy, so you label it as globulitis. But important thing is, whenever we label anything as globulitis, we need to be sure that immunofluorescence is negative. But if there is C3 deposits in this biopsy, then this could be endocapillary proliferation. There could be recurrent or de novo C3 globulopathy or post-infectious GN which is active. Okay. So there were these PTCs, and these PTCs were showing some cells. In addition to that, there were many PTCs which were significantly congested. You can see these RBCs in these PTC, and these RBCs are also seen in the interstitium. Whenever we see RBCs in the interstitium, so that suggests there is some amount of interstitial hemorrhage. So whenever interstitial hemorrhage is there, that happens mostly when there is a vascular rejection. Okay. In a transplant biopsy, if you see interstitial hemorrhage, possibly vascular rejection. In a native kidney biopsy, if you see interstitial hemorrhage, that can occur due to vasculitis. Okay. Again, a vascular pathology. Okay. Post-immune descending, you will find interstitial hemorrhage. C4D was negative, so this is C4D by immunofluorescence. In this, globular mesenterium act as a positive control. So that means I know my C4D is working because the globular mesenterium is positive. So that means it is negative in the peritubular capillary. So C4D is negative, but it is working correctly. So this was labeled as acute cellular rejection, 1A kinds, because there was infiltrate, there was some tubulitis, very mild peritubular capillaritis, but despite 3 doses, because obviously the moment you do biopsy, the same day you will give pulse, and next day the biopsy report will come, second pulse, and there may be third pulse, but the creatinine was rising. Okay, so they repeated this biopsy again. First was POD1 and then the repeat biopsy. This is the repeat biopsy. Now if you compare with the previous biopsy also, the ATN was there in the previous biopsy also. I'll show you. When I say ATN, so these are the tubules. So majority of the times the tubules are in back-to-back manner. You will not see separation of the tubules. When there is a lot of separation of the tubules, that means there is either acute tubular injury, interstitial edema is there. That is why you are seeing this. And even in this magnification, you can see some scattered RBCs which are there in the interstitium. That means there is interstitial hemorrhage. As compared to the previous biopsy, where I showed you only 1 or 2 RBCs here and there, here you are seeing collections of RBCs. Which I'll show in the high magnification. You can see this ATN which is there. There is interstitial edema. There are a lot of RBCs in the interstitium, and these are the PTCs which are congested. And some of the PTCs they were showing PTC capillaritis also. Here also 1 or 2 cells here, 3 cells here, 1 cell here, 3-4 cells here. So practically, as compared to the previous biopsy, the present biopsy was showing slightly more peritubular capillaritis. ATN has increased or remained the same. Yes, the only difference is as compared to the previous biopsy, the interstitial infiltrate has reduced. So most likely the steroid has acted, obviously the inflammation has gone, but the other component, that means the ATN, the PTC capillaritis, that is increased. Okay, so this is a silver stain. So silver stain also shows there is a lot of peritubular capillaritis and there is hemorrhage which is there. Now, if you compare with the previous biopsy, this biopsy showed a lot of cells within the glomerular capillary loops. So, what does that mean? That means there is a lot of glomerulitis in the present biopsy. And vessel was showing evidence of endotheliitis or intimal arthritis. There were two vessels which were showing evidence of endotheliitis. So, now look at this vessel. This is involving more than 25% of the luminous surface. So, it becomes a 2B kind of a thing. C4D again, it was like negative. But the behavior of this patient finally received plasmapheresis and all that, and creatinine improved after that. So what DSA lysate was done, which was like negative, but DSA lysate is not a very good thing. So I think now they have stopped doing DSA lysate, or still it is going.
So we usually do it on follow-up maybe. As such, primarily we go for the complete class 1 and class 2 DSA.
So this was clinical behavior was like AMR, even the morphology, if you see as compared to the previous. No, in my experience, these kind of biopsies, when there is no TMA, okay, when you don't find TMA, you find just glomerulitis, peritubular capillaritis and vascular lesion. ATG works very well in these cases. So many times when I see this, I say go for ATG, and some of these patients improve. So in this patient, obviously ATG was also given and plasma, so you don't know what acted. But whenever you see a vascular rejection which is not responding to steroids, ideally you should, before going for ATG, you should do a repeat biopsy just to see the progression. Like in this case, the repeat biopsy was done, that shows a drastic change. There was an interstitial infiltrate which was there, that improved, but the vascular rejection persisted. The PTC capillaritis increased, ATN increased, interstitial hemorrhage increased. So all these findings suggest surely we were dealing with an acute mixed rejection. The T cell component was taken care by the 3 pulses, and there is a possibility that now ATG works more with the T cell mediated, but it can work with AMR. Am I right? ATG can work in a setting of antibody mediated process.
We do sometimes.
You do sometimes. Yes. So, is there any sure shot evidence that ATG works in AMR?
Actually, usually they say that there is some.
You are also in final year.
Yes, sir.
Okay, good.
Sir, there is some possibility of. Usually they say that mixed cellular. I mean, it is mixed, though it might not be picked up, but there is some element of mixed with the cellular and T cell. I mean, both antibody as well as the cellularity. Then that's why they suggest that we should try that. I don't think so. Specific to skill, not specific for antibody. Yes, sir.
So this was labeled as C40 negative acute antibody mediated process. I'll show you now this third case. 28-year male renal transplant recipient, though the mother graft dysfunction, rising serum creatinine 1.4 to 2.8. There were 2 biopsies which was done. First biopsy was done on POD7, second biopsy on POD13. This was the first biopsy, and it shows dominantly there was no blue cells. Okay, so the blue cells were say around this vessel, which I show in the high magnification. So there is a lot of infiltrate but surrounding this vessel. Even in this magnification, you can see this vessel is showing a lot of blue cells inside. So as we go to, and there was smaller vessels also which was showing evidence of endotheliitis. So this biopsy showed 2 vessels. I can show you 2 vessels here. There is mild intimal arthritis here, and there is a moderate kind of intimal arthritis here. So practically 2B kind of vascular rejection. There was, as compared to the second case which I showed where the tubules are separated, look at these tubules. They are back to back manner. So there is ATN but very mild ATN. If you look at PTCs, they were showing some RBCs. Otherwise, there is no PTC capillaritis as such. So presence of RBC doesn't mean anything, but there has to be cells. That is why you label it as microvascular inflammation. Okay. So look at the glomerulus. The glomerulus is not showing. This is a PS stain. So glomerulus is, the capillary loops are empty, so they are not showing any evidence of glomerulitis. C40 was negative. So this was labeled as acute cellular rejection 2B isolated. So he was managed with 5 pulse methylpred, initial mild reduction in serum creatinine. However, after 2 days there was a rising trend. DSA lysate was negative and repeat biopsy was done on POD13. Now this is a repeat biopsy. So as compared to the previous biopsy, the present biopsy shows this vessel which is showing all pink color. That means it is a fibrinoid necrosis of the vessel wall. Okay. So as compared to the first biopsy, the second biopsy shows complete necrosis of the vessel wall. If you look at there were few vessels which were not showing fibrinoid necrosis, but they were showing more transmural kind of inflammation. So first biopsy, 2B kind of a thing, and the second biopsy is showing a transmural infiltrate. The first biopsy, no PTC capillaritis. The second biopsy showed lot of cells in the peritubular capillary. Even the ATN also, as compared to the previous biopsy, there is some separation between the tubules which is happening. That means the ATN is also slightly progressing. The glomerulitis also, which was not there, now the glomerulitis is also increasing. And the C4D in the first biopsy was completely negative with the PTCs, but the second biopsy showed some PTC staining. Okay, so this was acute antibody-mediated rejection. So what I want to highlight is this case and the previous cases. There were some isolated lesions. Some of these cases responded to steroids, pulse steroid, but there were one or two cases which progressed to antibody-mediated process. So Luminex single antigen bead assay showed class 2 DSA, which was an MFI. So I come to the same thing. So isolated V lesion. So majority of these isolated V lesions, they say that they can be if in absence of any microvascular inflammation. That means MI means microvascular inflammation, G means glomerulitis, PTC means PTC capillaritis. So if there is a I2 kind of inflammation, so what does I2 means? I1 means the inflammation has to be 10 to 25%. I2 means the inflammation has to be more than 25%. When the inflammation is more than 2, that means it is already T cell mediated, ACR1A. So here the inflammation will be less than 25%. T is tubulitis. So tubulitis less than 2. What does that mean? T1 means what? T1 means mild tubulitis, T2 means moderate tubulitis, T3 means severe tubulitis. So if you find tubulitis 1 to 4 lymphocyte infiltrating the tubule, that is T1. If you find 4 to 10 lymphocyte infiltrating the tubule, it is T2. And if you find more than 10 lymphocytes infiltrating the tubule, that is T3. So the tubulitis as well as interstitial inflammation both have to be less. V1 to 3, which I have told you, V1, V2, V3, any V lesion, C4D has to be negative, DSA has to be negative. Then only you can think of isolated V lesion or something of that sort. So isolated V lesion, actually if C4D is negative, treat like T cell mediated rejection. But 18% of these cases can be positive for DSA. So in patients with isolated V lesion plus DSA and microvascular inflammation, adding anti-B cell / antibody depleting strategies to steroids may prolong the graft survival. It is suggested that. Now there is a lot of mixed literature on these isolated V lesions. If there are some nephrologists and there is enough data to suggest that these isolated V lesions, they are not rejections. Okay, they say that it is due to ischemia reperfusion injury. Okay, some people say that those patients who receive similar, it is like an idiosyncratic reaction of the endothelium to those inducing agents. Okay, so there are papers which suggest that. So early isolated V lesion represent a benign phenotype of acute vascular rejection with a favorable outcome. There are papers which say that acute rejection or ischemic injury, early isolated V lesion. So intimal arteritis V lesion is a negative prognostic factor for renal allograft, kidney allograft survival. Early isolated V lesion do not always represent a pathological marker of acute T cell mediated or antibody mediated rejection. In particular, in the case of transplant negative for C4D and donor specific antibody, such a finding can suggest an ischemia reperfusion injury. Okay, so there is an intense debate in the literature concerning the origin of histological features. So there is, but the thing is, as pathologists, if I find vascular lesion, so I have to label it as a 2A or maybe isolated V lesion. I can't just say that it is a ischemia reperfusion injury. But the thing is, there is evidence in which they say that some of these are just benign kind of, even if you do nothing, they will resolve on its own. So that's why I showed you these 3 cases. Majority of them, they didn't resolve on its own, so it was treated and all that. But whether the treatment was required or 1 or 2 cases, the first case which I showed, where there was some intimal arteritis, responded to 5 pulses. I don't know if it was a ischemic reperfusion injury. But the thing is, so the biopsies for the isolated V lesion should be assigned a differential diagnosis on the basis of DSA, time and the presence or absence of mild tubular interstitial lesion. It is said that if you find some interstitial infiltrate with tubulitis and vascular lesion, you can label it as 2A. But if you find no inflammation no interstitial inflammation, no tubulitis, C4D is negative, DSA is negative, no microvascular inflammation, that isolated V lesion could be just a ischemia reperfusion injury. So before 1 year, and particularly in the first few months, isolated V lesion in a DSA negative patient usually do not reflect rejection, but the possibility of T-cell mediated rejection must be considered, particularly if there are some I and T lesion. That means if there is some inflammation and some tubulitis, you can label it as isolated V lesion, and these patients should receive T-cell therapy. But I'm very sure if pathologists say there is no inflammation, there is no tubulitis, there is a vascular rejection, you are not going to leave that patient like that. एक तो बस चढ़ाई चुके होते हो जब बायोप्सी होती है, दो ही देनी है और so after 1 year post transplant, they say even in absence of DSA, isolated V lesion usually means rejection. So that means less than 1 year in the first few months. If there is isolated V lesion, no tubulitis, no interstitial inflammation, no microvascular inflammation, DSA negative, C4D negative, it could be just a ischemia reperfusion injury, but still it could be rejection. But data suggests more ischemia reperfusion. But yes, if this lesion is associated with some tubulitis or interstitial inflammation, surely rejection, T-cell. But after 1 year post-transplant, even if there is no inflammation, even if there is no tubulitis, even if the DSA is negative, C4D is negative, no microvascular inflammation, it still means rejection after 1 year. So after 1 year post-transplant, isolated V lesion usually means rejection. Many are DSA positive, have AMR, so they say that many are DSA positive. And many times what I have seen is we don't do DSA in all our patients. If the biopsy is done, we are seeing vascular rejection, you are not going to go for DSA, you are going to treat it. Or you may say, I will do plasmapheresis, DSA is very expensive, so at least एक plasmapheresis हो जाएगा, DSA will cost around 45,000-50,000. 40,000 and your one plasmapheresis session will cost 60,000-70,000.
Yes.
So you will think सीधा पैथोलॉजिस्ट का नुकसान करते हैं, हम मरीज का भला करते हैं. So we'll go for one plasma, and obviously one plasmapheresis is not going to help. If you start plasmapheresis, you'll go for 3.
So at least like in such cases 5 sessions we do do, and maybe more if the DSAs are positive. Sometimes we might even extend the cover.
So after 1 year post-transplant, isolated V lesion usually means rejection. Many are DSA positive, have APMR, but some can reflect T-cell mediated rejection, particularly less than 5 years post-transplant. Isolated V lesion should not be used to diagnose T-cell mediated rejection, except in DSA negative patient who have at least some I or T.
So after 1 year ischemia reperfusion, does that thing apply?
No, that ischemia reperfusion we also know it is only in the first 2 weeks. So actually isolated V lesion many times you see in the first 2 weeks only. So it is possible that this may represent a ischemia reperfusion injury. So isolated V lesion, our results focusing on the relationship of isolated V lesion and humoral rejection suggest that isolated V lesion occurring in the first year post-transplantation is rarely associated with DSA, and that very few patients further develop ABMR. Isolated V lesion has a good prognosis but should prompt close clinical and histological follow-up because of its potential association with rejection. Further studies are needed and all that. So this was my data for the last 2 years. So isolated V lesion, we have seen 10 such cases. I showed you this case, one case like this. So practically majority of them, they behave like T-cell mediated rejection, but 1 or 2 cases like this case, plasmapheresis is received. This case, there is 1 or 2 more cases. C4D was positive, usually positive in 2 cases. So there are around 20% cases of these isolated V lesions which can have potentially chances of this being the antibody related to antibody mediated process. But yes, the last case which I am showing you 1 year 6 months, diffuse C4D positive to V1, that too literature also says more than 1 year post transplant if C4D is positive and V lesion is there, you have to consider it as an antibody mediated process. So the take home message with all these things are isolated V lesions are currently a grey area in renal transplant pathology. So if it is a grey area, better to treat, okay, rather than leaving it like that. Since its first description in 2009, there have been different speculations regarding its pathophysiology, whether it is a part of antibody mediated or cell mediated rejection or completely non-rejection process is not very clear. I just want to finish by showing these few images of one case, POD3 renal transplant. So, do you think there is a difference in this area and this area?
Yes.
What do you think? You must have seen many biopsies. Not many, but at least some biopsies. So tell me one thing, this is HND stain or PS stain? Very basic question. First I'll start. Great. So this is a PS stain, okay? So here what you can see is, as compared to this area appears absolutely different color. So whenever you see a different color in a biopsy, think of an infarction, okay? So this complete thing area is an infarcted area. So you can see this area is viable because you can see some bluishness in this area. If you don't see bluishness and you see just ghost outline of tubules and globular with complete loss of nuclear details. So nuclei, I told you, nuclei are blue. So if there is complete loss of nuclear details, no bluishness, and it is only the ghost outline of globuli, round structures and tubules, you should think of infarction.
So the pink thing inside.
Okay, so this pink thing inside, whenever there is a cortical necrosis or cortical infarction, the tubules, the nuclei, they shed off. Okay. They get necrosed and they lie within the lube. And sometimes there is hemorrhage also. So these could be leached out to RBC which are lying in the lube.
So when we describe it, what do we say that?
So you are not a nephropathologist, why you want to
So
do just,
I'm
telling you the examiner will also not be aware what is this. So if you say it is a infarction kind of thing, it looks different. And I'm seeing only outline, I'm not able to visualize any bluish area, that means there are no nuclei. It looks like, so whenever you see a contrasting kind of areas, you should think of infarction, okay? So there is infarction because just see, look at this tubule, you can see these nuclei and just look at this tubule, it is only outline, there is no nuclei, okay? So this is infarction.
So one glomerulus that is seen at the...
Yeah, so this globulus if you see, so this globulus also, the mesenterium and everything is gone because normally you see a supporting mesenterium. So what is happening is this is mesenteriolysis. Okay, mesenteriolysis is also a feature of, you can see infarction, you can see thrombotic microangiopathy. Okay, then this magnification you can see some neutrophils. So neutrophils in infarcted area you are going to see. We don't bother much about those neutrophils. But yes, in the non-infarcted area, as you went ahead, there was one vessel which was showing evidence of mild endothelitis. So what I want to show you is infarction with a vascular rejection also. So you can't ignore. Okay. So there one thing which I have seen over the years is, if I find multiple vessels with endothelitis, then it is not an isolated variation, then surely rejection. Okay. But if I find only one vessel in the entire biopsy with mild endothelitis, it could still be ischemia reperfusion. But if you find multiple vessels, chances are less. Okay. So then there was one vessel which was showing more significant intimal arteritis as compared to the previous thing. So this was patchy cortical infarction, but obviously C40 was negative. So I'm not sure whether it is just a acute cellular rejection to A. But since there is infarction, the chances are there that it could be antibody mediated rejection. So sometimes we get to see infarct post-transplant. Post-transplant first 1 week kind of a thing, those are mostly subcapsular infarct if they are not due to AMR. Subcapsular infarct can occur because during the surgery, if some tributary was cauterized and that supplies to kidney some portion, there could be a subcapsular infarct you can see. But if you find in the viable area some vascular rejection or the infarct is of a bigger size, then it is pathological. It can't be like just a surgical induced kind of a thing. So you need to remember that vascular lesions are obviously problematic, and any form of vascular lesion can occur in antibody mediated process. It is not like only V3 severe vascular rejection will occur in AMR. Another thing, it is always a combination. Vascular lesion plus microvascular inflammation plus thrombosis, TMA, C40, DSA, so all in combination. If you have any doubts or something.
Sir, in the slide where you had shown about tubular necrosis, so that sometimes there is cytoplasmic vacuolization seen. So is that visible?
Yeah. So the thing is, cytoplasmic vacuolization, I must tell you that it is not a finding which 100% says it is a finding you can see in any kind of tubular injury. cytoplasmic vacuolization. Yes, it is said that if the vacuoles are of the same size, see, it is very subjective. What appears isometric to me may not appear isometric to the other pathologists. But important thing is in CNI-induced toxicity, if I find classical vacuolization, which looks isometric to me, and I have team of 3 renal pathologists, if all other 2 also say yes, it is isometric, then I will say in my report. Otherwise, presence of only ATN, many times you people ask, because obviously that is what it is written in the textbooks. Now you don't ask those kind of things like stripe fibrosis. In the previous textbooks, stripe fibrosis means chronic CNI toxicity. Now you don't use those terminologies. So, because what we have seen is this kind of stripe fibrosis you can see in any vascular process. Even a hypertensive nephroscosis will show a stripe fibrosis. Okay, even in diabetes you can see those kind of stripe fibrosis. So presence of vacuolization doesn't mean CNI. Yes, ATN without vacuolization also. ATN means the first thing what will happen is there will be loss of brush border. I'll see if I can show you on this case. So brush border is more evident in if you are looking at PS stain. Okay, I'll see if this is HND stain only, but what I can highlight here is you can see these tubular nuclei 1, 2, 3. This is a tubule. Okay. You can see these tubular nuclei, and certainly this area there is no nucleus, and this one nucleus comes. Okay, so this also loss of nuclei means tubular injury. The first thing what will happen is these. You can see some. I don't know whether you will be able to appreciate, but this area looks pale. So these kind of vacuolization, this is vacuolization, and this kind of a non-specific vacuolization can occur due to CNI toxicity also. It is not like if it is isometric then only it is. So many times it will be just like a bland ATN, and if you it will be CNA, because you will say the levels are towards a higher range, so you can go to it. Majority of the times in the first 1 month, if there is ATN, it is possibly due to CNA. See, sometimes what happens is you will say that this patient during the surgery there was some complication. This patient was re-explored. There could be chances of ischemia, reperfusion injury. So ischemic ATN, if it is a severe kind of ATN, you will find necrosis of the tubular cells. Okay, so if you find necrosis of the tubular cells, that is more towards a ischemic kind of ATN. Sometimes we used to see cases also ethylene glycol or drug-induced toxicity. Sometimes there will be a toxic ATN, which we say, and toxic ATN will be again necrosis of the tubular epithelial cells, and it will not show these kind of vague vacuolization. It shows complete necrosis. That is why people say, don't say ATN, acute tubular necrosis. There is no necrosis going on. Just say ATI, acute tubular injury. But we are used to ATN. So if I use, sometimes I reported ATI, so it means ATN only. Yes, it means ATN. So it is just that we become used to some terminologies. So if I say ATI, it is going to cause confusion. So I say ATN only. But yes, there are group of pathologists who prefer terminology, which is correct actually. If you go by it is very similar to membranous glomerulopathy or membranous glomerulonephritis. Itis means inflammation. So if there is no endocapillary proliferation, there is no activity, why to label it as glomerulonephritis? Label it as membranous glomerulopathy. So some will prefer that. So that has to be there. Opposition should be there and ruling party should be there. So it becomes interesting. Yeah. So you should go with the simple concept that vascular ejection can occur, any type of vascular ejection can occur in AMR. If severe vascular ejection commonly associated with AMR, not like underburst commonly, but yes, all other features in combination should be there. That's it. And acute mixed rejections are, I must say acute mixed rejections are not very common. I am not saying they are rare, but they are not very common. So don't, I remember there were times when they used to give everything. They will not biopsy. They will give plasma also, ATG also, everything is done. Now, if you do biopsy, it has no meaning. You won't see anything. But the thing is now that scenario has changed, which is very good, because otherwise plasmapheresis was like. The only problem we face as a renal pathologist is in an APO incompatible setting. What happens is you start your CNIs in APO compatible setting a week before, or maybe 10 days, a week before. So that patient is exposed to CNIs earlier as compared to the conventional transplant. So we see TM, and the TM is majority of the times in a routine conventional transplant, the TMA due to CNI is very focal. If there are 10 globula, there will be 1 or 2 globula which will show TMA. Rest of the globula will be fine. And majority of the there will be 1 or 2 globulus in which the globular hilar vessel will show endothelial cell swelling or TMA. And we'll say since its TMA is very segmental, very focal. So you know the difference between focal and segmental? Sure. Focal.
So only some of the lobes,
Okay. Segmental.
part of it.
Very good. Global and diffuse. Opposite to that. Diffuse means more than 50% global. Very good. Okay. So if you find segmental TMA, likely CNA. If you find diffuse TMA, more than 50% global showing thrombotic microangiopathy, majority of the vessels showing TMA, more like AMR or de novo HUSTT. Okay. Now problem is antibody mediated, ABO incompatible. ABO incompatible, some cases TMA is significant, it is diffuse and still due to CNA, not due to AMR. Sometimes some pointers are there which suggest that this TMA is possibly due to AMR if we find some globulitis. The problem with ABO incompatible setting is AMR present as TMA and then cortical necrosis. You don't see, so there is no time for microvascular inflammation to come. Before that only everything happens. There is sudden endothelial injury which leads to TMA, and then there is cortical necrosis. So there is no time for microvascular inflammation to come in. So that microvascular component, morphological component of microvascular inflammation, that is not useful in ABO incompatible setting. And that is the most useful component based on which we differentiate CNA induced TMA or antibody mediated induced TMA. So that is a problem we face. But yes, we say withdraw CNA, give plasmapheresis, you are able to cover up both. So still there will be some cases where we feel it is possibly AMR, and then obviously nephrologists will say the DSA is not the anti-HLA antibodies, they are not rising. But we have seen cases anti-HLA antibodies are not rising and patient has landed up in graft nephrectomy. It doesn't correlate. But yes, in this kind of a scenario, you may say, okay, if the patient is improving, the HLA antibodies are fine. So it is like a learning kind of thing, but it happens only in selected cases, not in all cases. And many times, you know the clinical behavior. C4D accommodation, what I feel, first 10 days post-transplant, ABO incompatible setting, if C4D is positive, take it as a pathological thing. So in my experience, if C4D is positive in the first 10 days, 7 to 10 days, because accommodation will take some time, it is not going to develop in the first 7 days, it takes some time. But yes, if I try to study this, that in the first 10 days, if I reported C4D, how these ABO incompatible setting, in an ABO incompatible setting, how these patients have behaved. 90% they behave like A. 10% cases they behave like just ETN kind of a thing and they improved. Okay, nothing, no plasmapheresis was done. And sometimes what happens is the nephrologist after doing the biopsy they will start plasmapheresis. So I don't know what happened. But then I'll say there is nothing, please stop. No point continuing with this plasmapheresis. And patient is small also. So accommodation, so that in that way C4D helps. I have seen cases in which on table the transplant was done, everything fine, just maybe after 45 minutes, 50 minutes something happened, they did a biopsy. 50 minutes there was a minimal C4D still. Plasmapheresis was started, no improvement. 24 hours biopsy done. C4D intensity increased. And after that, cortical necrosis. So you don't know which patients will behave like. Some say that those patients who have some complement abnormalities, they develop more of this TMA. Okay, but how will you assess who are those patients who have complement abnormalities? Why the endothelium is reacting in that way?
This early C40 positive is in the peritubular cap.
Yeah, peritubular. So glomerular capillary C40 staining has meaning only in chronic antibody mediated rejection. Acute antibody mediated rejection mostly it is. See what happens is the concept of C40 staining in the glomerular capillary loops also. There is an endothelium. There is an endothelial injury, and if there is a repeated endothelial injury, the C40 will get deposited. So since there is a repeated endothelial injury to the endothelium, there is thickening, there is repair. And due to repair, there is a new GPM which is formed, new glomerular basement membrane. That is why you see duplication, because there is a new membrane and there is an old membrane. What happens in application? The concept is same. Recurrent injury, recurrent persistent antigenemia, repair, regeneration. That is why you see those duplications. So transplant glomulopathy, I told you before also, transplant glomulopathy is not synonymous with chronic antibody mediated rejection. So when you say transplant glomulopathy, it is a morphological term. What you are saying is there is a glomerular capillary wall duplication. What are the reasons for glomerular capillary wall duplication? What are the causes for transplant glomulopathy? Oh, no. Listen. You are seeing the globulus. There is thickening of the glomerular capillary wall and there is duplication. You label it as transplant glomulopathy. So what are the differentials you will consider? If there is a transplant glomulopathy in a kidney biopsy, in a renal allograft biopsy, what are the differentials you will consider? मैंने पहले भी बताया था लेकिन हमेशा मैं बताता हूँ ये तो यार. So
DNB MPGN
हाँ तो बिल्कुल तो मैं इसको बता दिया. So the thing is transplant glomulopathy doesn't mean it is chronic AMD. क्या होता है? In the biopsy, sometimes on the test requisition form you will say TG. So you feel that TG means I have given my diagnosis, it is chronic AMD. No. So TG means there are 4 differentials I have to consider. As a pathologist, and you should also know, there are 4 differentials. I think 4 or 3, whatever. I'll tell you. So the first differential is it is chronic antibody mediated rejection. If C40 is positive, I see microvascular inflammation. I see glomerulitis, peritubular apparatus, that is microvascular inflammation. C40 is positive, and then I label it as a chronic AMD. Now C40 is negative. There is no microvascular inflammation. One more thing, electron microscopy will show peritubular capillary basement membrane multilayer. Okay, so we come to the second scenario. There is transplant glomulopathy, that means you are seeing duplication of the capillary. So transplant glomulopathy by definition means there is just duplication of the glomerular capillary wall. So if there is duplication of glomerular capillary wall, that on morphology we label it as transplant glomulopathy. So if C40 is positive, microvascular inflammation is there, electron microscopy show peritubular capillary basement membrane multilayering, we label it as chronic antibody mediated rejection. Okay. If C40 is negative, no microvascular inflammation, EM is not showing any peritubular capillary basement membrane. Peritubular capillary basement membrane multilayering, पता है या नहीं पता? Okay, नहीं पता बताओ ना यार, पूछो फिर. So normal. So electron microscopy, if you do electron microscopy of the glomerulus in a chronic AMD, it will show glomerular basement membrane multilamination. That means, as I told you, 1 membrane, 2 membrane, 3 membrane. So there will be multilamination. And the peritubular capillary. Since endothelium is there in the peritubular capillary, also peritubular capillary is lined by endothelium, and there also microvascular inflammation is occurring. In the glomerulus also glomerulitis is occurring. Repeated lymphocyte interacting with endothelium causing injury. Similarly, repeated lymphocyte interacting in peritubular capillaries interacting with peritubular capillary endothelium causing injury. Both will show thickening. So PTC will also get thickened. PTC can also show duplication. Okay, but you don't use that word duplication in the PAM classification system because duplication is seen mostly in the glomerular capillary. So PTC duplication can be visualized only in the electron microscopy. If you find peritubular capillary multilayering, that means around the peritubular capillary there are new membranes which are formed. So if more than 7 layers are there in a peritubular capillary, it is diagnostic of peritubular capillary basement membrane multilayering. Okay, or if there are 3 PTCs with 5 to 7 layers, 3 3 PTCs with 5 to 7 layers or even a single PTC with more than 7 layers. It is PTC multilayer. So if there is no PTC multilayer, there is no microvascular inflammation, C4D is negative, and you are finding transplant globulopathy. Then the other differential is chronic CNA toxicity or chronic hypertension induced chronic TMA. Chronic TMA is the second differential diagnosis for transplant globulopathy. Okay? Got it? Then the third differential is immunofluorescence is positive. IgG is there, C3 is there, and you are finding duplication. MPG. So these are the 3 differentials we consider. So transplant globulopathy means 3 differentials. So whenever you say TG, I know you mean only chronic AMR, but I know I have to consider all this. Or you say chronic rejection, chronic allograft nephropathy, you don't use these words scan now. Don't use that. You use IFTA. IFTA is a new terminology, don't use scan. I think 2005-2006 they stopped using that word, but still many people just say CAN, chronic allograft nephropathy. Anything?
This one, it's a C4D. They say that the covalent binding is good with the peritubular area as compared to the glomerulus. So do we use the C4D staining of glomerulus for anything? Or?
Yeah, C4D staining for glomerulus is used only in a setting of chronic antibody-mediated rejection. If there is a transplant globulopathy and I am not seeing any staining in the peritubular capillaries, and I am seeing staining only in the globular capillary wall, okay, I will still say I favor chronic AMR. Okay, but the important thing is there should be no ischemic globular changes, because ischemic globuli, they somehow non-specifically there is non-specific trapping of C4D. So if my light microscopy morphology show no ischemic changes, it show proper duplication, there is glomerulitis, there is PTC capillaritis, even if C4D is negative in the peritubular capillaries, but I see globular capillary wall staining, because C4D, as I have told you, it should be in the mesangium. If I see in the globular capillary wall in a setting of chronic AMR, I will label it as chronic AMR.
So one of the examiners asked that is C4D positivity is present in the glom but not in the peritubular. So can you label it as acute rejection? So should we say that we should not?
So the thing is, if C4D is present in acute rejection, it should be in the peritubular capillary. The problem with C4D is 40 to 45% times in a chronic rejection, C4D will be negative. But I must tell you, all my cases which I have showed you, acute AMR, majority of the time C4D is negative. What to do? So initially our concept was C4D is negative only in chronic AMR, 40%. But majority of the acute AMR also C4D is. See, C4D if it is positive, very good. But if it is negative, it doesn't rule out AMR. So next month exam. अभी है stains पता होने चाहिए, ये ना हो कि if somebody asks you interstitial fibrosis के लिए कौन सी वो तो starting में पहले first year के लिए ले लो. So special stain जो है Mason's trichome for interstitial fibrosis. Mason's trichome. So normally if somebody asks you which of stains do you use, so HNT stain. HNT stain is very good in saying interstitial inflammation is there or not there and all that. But if you want to visualize the globulus, globular capillary basement, somebody asks, some examiner asks which is the best stain to look at globulus, to look at globular abnormality. You don't say HNT. You say either a PAS stain or a silver stain. Silver stain is black stain. I showed you one stain with a black color and all that. So this stain, you can see a blackish appearance. So this is silver stain. Okay. This is HNT stain, hematoxylin and eosin. इसमें ये PS stain है ऊपर, ये PAS है, because why PS? Look at the Bowman's capsule, कितना अच्छा सा magenta color दिख रहा है. And look at this is silver stain. Look at the Bowman's capsule black color. तो जहाँ तुम्हें Bowman capsule black हो तो silver, जहाँ तुम्हें magenta दिखे तो PS.
HNE वाले एक दिखा देंगे.
क्या क्या?
HNE वाला भी एक.
हाँ HNE वाला भी दिखेगा.
Western membrane.
क्या? इसमें नहीं दिखेगा. इसलिए if you want to demonstrate globular abnormalities, PAS and silver stain. Silver stain is black stain. Don't say black stain. Silverstein. So PAS and Silverstein. And Mason's diagram for interstitial fibrosis. Amyloid, congruent. Okay, tell me one thing. If there is some material which is showing apple green birefringence, and examiner is not going to ask. So if any material is there which is showing apple green birefringence, so it is good enough to label it as amyloid. Apple green birefringence. You must have read this term.
Yes, sir.
Apple green birefringence. पढ़ते थे यार MBBS. So see, important thing is, first important thing for amyloid, the material should be congophilic. That is the first important thing. If congophilic is not there, even if it shows apple green birefringence, it is not amyloid. It has to be congophilic, and then along with that, it should show apple green birefringence. Then it is amyloid. Okay. If it is non-congophilic, then it is not amyloid. Got it? Because even collagen can show apple green birefringence. Okay. So it has to be congophilic.
That when you use the Congo red stain.
Congo red stain, it will appear orange. So it will take up the orangophilia, orange color. So someone will say, do you think special stains are required in kidney biopsy? Yes or no? Yes. Okay. Do you think if some pathologist say, your pathologist say that I will study everything with HAT and then I'll decide whether I want to do PS, silver stain, Congo red stain. Is it correct? Yes or no?
At least pass should be there.
Yes. You should say at least pass, at least he should be doing PS stain, because if there is early amyloid and glomerular abnormality will be picked up only on the or otherwise I will report if he is not reporting. Okay. So this thing is very important. And do you think that without immunofluorescence kidney diagnosis can be made? No, yaar, ऐसा मत बोलो. No, yaar, this is a crime. If somebody is doing a kidney biopsy as a nephrologist without immunofluorescence, that's a crime. You should not do that. Okay, so they will ask C4D if you are able to get only one core in a transplant biopsy. So, will you prefer, why you want to take two cores in a transplant biopsy? There is no proteinuria. Okay, you have taken up one core. So, will your pathologist be able to do C4D immunofluorescence? Because you haven't taken a separate course for immunofluorescence. How will he do C4D immunofluorescence? What is the answer to that? So, you can always do C4D immunohistochemistry. So, there are two methods of doing C4D. One is immunofluorescence, one is immunohistochemistry. So, what we do SV40, it is immunohistochemistry. So, on the paraffin tissue, what we do, that is called as immunohistochemistry. On the fresh frozen tissue, what we do is immunofluorescence. Okay. So, if in a native biopsy you are able to take from only one core, you are not able to. That patient was not cooperative. He was obese, he or she was obese, and you are able to take out only one core. What will you do? And this patient has RPGN kind of presentation. You haven't taken separate course for IF. You have taken only one core. What? Yes, you can. Yes, that could be the answer. You can cut it. Or you can ask your pathologist that if they can do paraffin immunofluorescence on that.
And sir, they say that if one core comes, even then the pathologist is able to use it for.
So for that you need a dissecting kind of microscope. You should be able to visualize that when you are cutting one end of the core, you should be able to visualize a globular kind of structure which will be globulous for sure. If you cut the ends and it is showing only medulla, then there is no point. So no one has a dissecting microscope, and in India, no pathologist at that much time that he is going to look at single core. If you are getting 10-12 biopsies, no pathologist, otherwise he will be all the time looking at those cores only. I am not able to do microscopy, I am just visualizing whether globulus is there or not. But now with paraffin immunofluorescence being there, it is a very useful modality. So even with one core, we have reported cases, single core, did a paraffin IA, and the remaining part of the tissue was sent for electron microscopy also.
It's about LM and
LM, formalin, we did. After that, after looking at the formalin thing, we made our differential diagnosis. Then we did paraffin immunofluorescence on the same tissue. Immunofluorescence was there, then a small amount of tissue was left. So in those cases, what we do, we don't do complete 10 things. We will not prepare 8 or 10 slides because we know if we prepare 10 slides, there could be limited tissue left for electron microscopy or immunofluorescence. So we may study only 6 sections or 5 sections. So we'll preserve the remaining tissue. ठीक है जी. Anything more? All the best.